joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Adam Zoga, Dr. Rosemary Klecker, and Dr. Paulo Helito. This session will focus on sports imaging, and the speakers will present their cases, and at the end, we will have a Q&A session. If you have any questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. And just a quick reminder, attendees have not been given the permission to screen recording of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and Hilary will introduce our first speaker today. We can't hear you, Hilary.
I do that every single time. Okay. Okay, I am delighted to introduce my good friend, Dr. Rosemary Klecker, who received her medical degree from George Washington University of Medicine in Washington, D.C. She actually completed a surgical internship at the Medical College of Georgia in preparation for a neurosurgery residency, but there lost because she switched to radiology. She completed her radiology training at the Ohio State University Medical Center in Columbus, Ohio, and that was followed by a musculoskeletal fellowship at the Brigham and Women's Hospital in Boston, Massachusetts. She stayed on as faculty at Brigham and Women's Hospital for a short time before starting as the director of the MSK radiology section of the Cleveland Clinic in Central Ohio. She left Cleveland Clinic for private practice, but after several years of private practice, she realized her passion was in academics and accepted a position at the University of Southern Alabama, where she is currently an associate professor of radiology, assistant program director, and chief of musculoskeletal imaging at University of South Alabama. Okay, Rosemary, the screen's yours.
Wonderful. Thank you so much. So did I share the correct screen? You can see this?
Yes, perfect.
Okay. All right. Well, thank you so much for that introduction. It was quite a mouthful, and I appreciate that. So today I'm going to talk about in the sports imaging emphasized conference, batter shoulder, which was something I was not as familiar with previously. So I'm going to start with a couple cases. The first case is a 16-year-old male. He's a left-handed thrower and left-handed batter. He presents with a history of right shoulder pain for the past 9 to 10 months, which began after batting practice when he swung through the pitch and felt a pop in his shoulder and immediate pain in the posterior aspect of the shoulder. This felt very loose at first, but over time, he was able to reduce it, and it got stronger and was able to continue practice. Season changed, he went on to play football, and after that initial injury, he sustained another injury in football practice while doing blocking drills. At that time, the pain was significantly greater. It radiated across the front of the shoulder to the back of the shoulder and down to the elbow. So he underwent some imaging. Physical examination, positive posterior shifts with 2+ posterior translation on examination. He had positive apprehension and relocation, a positive jerk test, a positive O'Brien, and he was able to give thumbs up and cross finger sign and make the okay sign, and the sensation was intact. So underwent an arthrogram, an MR arthrogram, and here's some axial images. So this pretty extensive labral tear starts with a near circumferential labral tear, a superior labral tear that goes all the way down through the posterior labrum predominantly, and also had anterior labral tear, which may have been sustained during football practice. So we have these coronal images showing the posterior labral tear and the slap lesion. And then again, the sagittal image showing the extent of the posterior labral tear, and then the axial image. So here's our second case. This is a 20-year-old baseball shortstop at University of South Alabama. He is a right-handed thrower and a right-handed batter. He presents with left shoulder pain. He was swinging a bat at practice when he felt his shoulder slip out of place. This was spontaneously reduced on site, and he had gone to go see the trainer and our sports experts at the University Hospital, where he admitted that this had happened once before in the past when he was in high school. And at that time, he had undergone PRP injection and had returned to play and was pretty happy with the result before when he was in high school. So we had an MR arthrogram, showed some irregularity here along the posterior labrum. And let's go through it. So he had undergone, so again, he did not want to have surgical procedure to repair the posterior labral tear. He wanted PRP, which our physicians replied and agreed with that, but said, if this happens again, come back in because this will have to be repaired. So he continued to play, but had several subluxations during play and finally underwent operative treatment for labral repair in February. So in the op note, it showed an extensive tear of the posterior labrum from the 11 o'clock to 6 o'clock axis with minimal fraying of the anterior labrum. And we have the stars at the sites of the, that's pretty extensive posterior labral tear, but we can see the little gap right here. And this looks like it's not all that acute posterior labral tear. And here we have on the coronal images. So these two players, what do they have in common? They have posterior shoulder instability, but they have batter shoulder. This is the less common etiology of posterior shoulder instability. We're used to seeing anterior shoulder instability, but this posterior shoulder instability is present in approximately 2 to 12% of the posterior instability issues. And this may present insidiously over time as kids practice, batters hit younger and have micro trauma until that later it just gives out. Or it could happen all at once, as we did with these cases where they felt a sudden pop or snap and they had an acute subluxation posteriorly. The subluxation or frank dislocation, which is rare, but these very rarely require reduction. They self-reduce or they're reduced on site. They rarely go to the emergency room for the reduction of these. Now, this issue involves the lead shoulder, which is the anterior shoulder when you're sitting in the baseball stance, getting ready to bat. The forces of the swing are transmitted to the posterior glenohumeral joints of the lead shoulder, and the shoulder can sublux posteriorly, causing injury to the labrum and even the capsule. So we're used to seeing posterior shoulder instability issues in other sports and issues, such as football, weightlifting, and even baseball at the end point of the pitch. The mechanism of the posterior shoulder instability or batter shoulder is an axial loading to the adducted and fully flexed arm. In batter shoulder, in batting motion, you have a buildup of kinetic energy as you wind up to get ready to hit the ball. During the swing, there is a significant shift weight posterior to anterior as you put the lead foot down and uncoil the body, unwrap the body to swing through to hit the ball. And this is why the lead shoulder is injured, because during all this torque of the body and the swing of the bat, the lead shoulder or the anterior shoulder here goes through extreme internal rotation and adduction. So during the acceleration phase, there could be a buildup of approximately 500 newtons of force across the posterior glenohumeral joint, and that's a lot. Certain pitches can be more problematic, particularly if they are low and to the outside, where the angle of the shoulder, this is not one of those, this is Penna hitting a home run, yay, nice swing. So it just shows that the force after the windup, this is close in slow motion, all that force goes through the bat and hits the ball. So if it's pitches down low and to the outside, there's greater adduction, which puts even greater force on the shoulder and the posterior glenohumeral joint. And if it's a swing and a miss, that energy just does not go through the ball or the bat and perpetuates, and is thought to be cause of more acute presentations of batter's shoulder. So this is showing that angle, this increased adduction here. So this pitch was supposed to be low and to the outside. So you'll see here, little Yankee player. So the increased adduction here, the shoulder to the body, increases the torque and increases the likelihood of batter's shoulder here. So there's that angle. On this little batter right here. And this is less. So when you have the pitch that's more on the inside or straight on, you don't have that increased adduction. Adduction is not as great, I should say. So the treatment options, you can have non-operative, which is rest, rehab, and then gradual return to batting training. And then of course, surgical indications. Failure of non-operative treatment is the number one. Positive jerk test, or prior incidents of immediate posterior subluxation. So the positive jerk test is when it pops back in, when it reduces, and you can hear an audible click. If the patient's symptomatic, that gives it a higher likelihood that this should be treated surgically rather than non-operatively. Of course, surgical indication, other indications for that are seasonal timing and seasonal and career timing for the professional player. So in conclusion, batter's shoulder is posterior instability of the shoulder, which from chronic or episodic subluxation of the lead shoulder during the baseball swing. It typically results of posteriorly directed load on an adducted shoulder swinging through the bat, and shoulder injury is more likely to happen if there's a swing and a miss in an adductor shoulder, particularly when that pitch is low and to the outside. This may be sudden or insidious onset, and it's different from the pulsal lesions we see in football or weightlifting and other mechanisms, as it involves the leading shoulder, which is often the non-dominant shoulder. All right, that's all I have right now, and I thank you so much for your attention.
Thank you very much, Rosemary. Okay, now it's my pleasure to introduce Dr. Paulo Helito. He's a musculoskeletal radiologist at Aspetar in Doha, Qatar. And he graduated with a degree in medicine from the University of São Paulo, a medical residency in radiology and diagnostic imaging, a fellowship in MSK radiology, and a doctoral degree in medical science at the Instituto de Radiologia no Hospital das Clínicas in São Paulo. He has co-authored book chapters and authored and co-authored several papers on MSK radiology, orthopedic imaging, and other areas, including imaging of the spine, neuromuscular disorders, and rheumatology. He's an active participant of the Sociedade Paulista de Radiologia, where he has coordinated the MSK group from 2017 to 2019. And he's also a board-certified radiologist member of the Brazilian College of Radiology. Please, Paulo, share your screen.
Okay, so thank you, Aline, for the introduction. It's a pleasure always to be part of the OCAD. I hope my case is as interesting as Rosemary's one. Let's show the clinical case. It's a 35-year-old professional handball player He had a previous rectus femoris muscle injury and now acute posterior thigh pain during practice. And he came to us to evaluate a possible hamstring injury. So this is, I'm going to show the images of the MRI of the right thigh. We have the sagittal and the coronal T2 fat set images showing a tear here in the posterolateral aspect of the right thigh that we're going to see that it's in the long head of the biceps femoris muscle. So following the axial images, we can see the hamstrings here, long head of the biceps, semitendinosus and semimembranosus. As we go further down, we start to see a laminar hematoma here in the posterolateral aspect of the long head of the biceps. Again, long head of the biceps. This is the proximal myotendinous junction, and this is the beginning of the distal myotendinous junction, and this is where the laminar hematoma is. As we're going further down, we see that the hematoma gets larger, and we start to see the injury in the distal myotendinous junction. Okay, we start to see some small areas of architectural disruption and a larger area here involving this whole area here, involving the whole posterior, lateral, and anterolateral margins of the muscle belly and the whole distal musculotendinous junction. So what is interesting and what I like to highlight here is that the injury goes in between the short head of the biceps femoris and the long head of the biceps femoris interface. And this is what is the particularity of this case. So we can see that the tear goes all the way in the interface between the two muscle bellies. And we have an extensive tear. We also, if we can follow the distal end of the proximal myotendinous junction here in the blue arrow, we can see that there is also an injury smaller here in this area, but it's by far not as large as the distal one. When we compare with the previous MRI that he had performed because of the rectus femoris injury, we can see that in the same level of the injury, we can see that this is where the distal myotendinous junction of the long head of the biceps goes through the interface with the short head of the biceps, and this is what is particularly interesting of this case, because this is what we call the T-junction. So this is the diagnosis of the case is a long head of the biceps femoris tear involving the T-junction. And we are going to look into the concepts of this anatomic structure. So a brief overview of hamstring injuries. We all know that they are really common in sports athletes. And they result in absence and they have risk of re-injury. The long head of the biceps femoris is often involved in up to 70% of the cases, with re-injury rates of up to 63%. And imaging, it's really controversial where imaging makes a difference to prognosis, to identify the prognosis of the athletes, but we have evidence that intramuscular tendon involvement is often associated with longer recovery time and higher re-injury rates when we're dealing with professional athletes. And MRI used often to evaluate the injury size, the location, and the involvement of the intramuscular tendon. There are several classifications. I'm not going to discuss them because this is a really large topic. But what I am going to discuss is the particular anatomy of the biceps femoris muscle. So it has two origins. It's a biceps, so it has two heads. The long head has an origin in the ischial tuberosity and the short head along the diaphysis of the femur. And it inserts in the fibula, the lateral collateral ligament, and in the lateral tibial condyle. One particular interesting thing about the biceps femoris is that the long and the short heads have different innervations. And this dual innervation is one of the postulated causes for the high rates of injury, because it can result in asynchrony during the contraction of the long head and the short head. And this is one of the reasons people believe that the hamstring, the biceps femoris is the most commonly injured hamstring. But the biceps femoris has two distinctive anatomy characteristics. The first one is well known, the conjoint tendon, in which the biceps femoris has an origin with the semitendinosus, and it can take up to 10 centimeters before we can individualize the tendons for each muscle. As well, but there is also a particularity in the distal anatomy, because the ventral portion of the distal tendon can serve as the insertion of the short head of the biceps femoris. And this is what Entwistle described in 2017. This is one image of the paper that he named this insertion of the short head of the biceps in the long head of the biceps muscle as a T-junction, because of the morphology of both myotendinous junctions. And he described a really high rate of re-injury in biceps tears that involve the T-junction. Well, this is still controversial, because there is a second paper that by Karen in 2024 that described that he didn't find this higher re-injury rates in the involvement of the T-junction, but it's all really recent if we think about it, because it's one paper is from this year and the other one 7 years ago. So I think this is something that we're going to have to learn more to understand the impact of this in the re-injury rates or the time of absence in practice and in matches. So to recap, the relevance of imaging, as I have discussed, is often controversial, but as we all know, MRI and ultrasound are really frequently requested and performed in athletes with hamstring injuries. And we know that the size of the injury and the involvement of the intramuscular tendon can be associated with longer return to play. And recently, we have this description that the T-junction involvement of the long head of the biceps, of the biceps femoris, has higher rates of injury, although this is definitely going to be further studied. But one other thing that I found really interesting is one meta-analysis of hamstring injuries that said that the description of hamstring injuries in the papers are often poor and do not take full advantage of the MRI strengths. And this is something that really caught my attention, because I think that definitely MRI has a incredible potential to describe really particularities of each injury, and we have to take notice and to describe this particular anatomy of injuries. So this player had a re-injury at the same site at the T-junction with a hematoma. Now we can see the scar tissue here and a hematoma inside. And this particular case was one that did not had a good prognosis. So the take-home messages that I would like everybody to remember is that the biceps femoris has an interesting and complex anatomy. And most of I've been remembering my previous OCAD presentations, and most of the times I always say something about anatomy, because I think this is something that we radiologists, most of us, are really passionate about, and something that there are some subtle things anatomy-wise that can make a difference for individual patient treatment. And to understand and to get to know this anatomy of the T-junction and the possibility that these injuries can have higher rates of re-injury. So if we have the possibility to talk with the clinicians, I think it's interesting to advise them that injuries may have a higher rate of re-injury and poor prognosis. And of course, to remember all the strengths of the MRI, and we have to take full advantage of them in our day-to-day practice and in further on whenever we are doing research. Thanks for the attention. Thanks, Hilary and Aline.
Thank you, Paulo. That was a beautiful case. I'll save my questions for later.
Okay.
Okay. Now, last but not least, I get to introduce Dr. Adam Zoga, who's been with the musculoskeletal section of the Thomas Jefferson University in Philadelphia since 2002, after receiving his medical training at Georgetown University and residency at Boston University. More recently, he received his MBA from the Fox School of Business at Temple University in 2018. Professor Zoga serves as the Vice Chair for Clinical Practice in the Department of Radiology and is the Enterprise Sub-Council Leader for Radiology Protocol and Pathways at Jefferson Health. He served as the Program Director for the MSK Fellowship from 2006 to 2019 and currently remains the Program Director for the combined MSK Neuro MRI Fellowship. Adams co-authored more than 120 scientific papers and 30 book chapters. Notably, Adam was awarded the best paper at the SSR in 2007 for sports hernia. What is it? How do I image it? I remember it made a splash, and that spawned numerous articles and myriad lectures on the topic. He's also, relevantly, the Director of Imaging at the Vincera Institute, a center focused on diagnosis and treatment of core muscle injury. Since receiving his MBA in 2018, Adam is focused on optimization of imaging operations to meet health system needs and distribution of imaging services across populations. That sounds very important. Okay, Adam, take it away.
Thank you, Hilary. And I need to be enabled to share my screen.
Eleni. He can't share a screen.
I get the pop-up that I'm disabled from the screen share.
Ok. Milene, ele está dizendo que ele não consegue compartilhar a tela dele. Você pode desbloquear, por favor? Just a
So
second.
while we get that going, I'll give you the background. I see a lot of throwing athletes in my practice, and we take care of a whole bunch of baseball players. And for Major League Baseball, all the players go to spring training in either Florida, Arizona, or California at the start of the year, and they train and they get ready. And this was a baseball pitcher. I think he's 29 years old. He's a professional baseball pitcher. And during a throwing session, he noted that he had a cold feeling and numbness in the third digit, his middle finger of his throwing hand. The team doctor at that point And they have one team doctor down at spring training at the time. There we go. I've been made co-host.
Yes. Okay, great.
The team doctor was a specialist in really joint knees, right? He's not a general orthopedist or sports medicine doc. He's a joint knee person. But he felt, the team doc called me and said, I've got this crazy case. I think this guy has something wrong with something vascular in his hand or wrist. I said, Doc, you sure it's not thoracic outlet syndrome? Because we see that a lot. And he's like, I'm pretty confident it's in the wrist. So I've gotten to that. So he flew home from Florida to Philadelphia, and we set him up with an ultrasound and an MRI. We started with ultrasound, and we have a really fabulous ultrasound technologist who did a thorough study. We looked at the radial artery and its flow. We even put some waveform analysis on it. It looked fine. We looked at the ulnar artery. It looked fine. There was nothing. We went more distal, and we looked at the digital arteries in the hand. There's the ulnar artery at the wrist. Everything looked fine. A digital artery along the third finger, we didn't find anything. We looked at the muscles in the hand and the tendinous structures, and we really didn't find anything, focusing on the third finger. So it was a negative ultrasound, and I think it was a good study. So I had differential considerations at this point. I think I've seen it all. I've seen all these pictures with these sort of symptoms, and I thought it was going to be transient exertional thoracic outlet syndrome. Considered brachial plexopathy, an intrinsic muscle strain in the forearm or hand that we didn't see with ultrasound. I did not believe it was going to be a peripheral small vessel vasculopathy or an occult nerve lesion, but they were on the differential. So we set him up for MRI, and we started with some non-contrast imaging in the area of concern. And I didn't come up with much on this proton density weighted fat suppressed sequence. I looked at the anatomy on T1, didn't come up with much. But then we did a 2D time of flight, and this was odd, right? We haven't given contrast yet. This is just time of flight. And the third finger does not have as much vascular flow as the others. I also examined this player before he got in the MRI, and I didn't see anything. It looked normal. His hand looked normal. He couldn't come up with much. He actually said that the symptoms were worse when he was working with his phone than they were with throwing, which I thought was odd. So here's our 2D time of flight, something interesting. We got some post-contrast sequences, but the slices are thick, and I really couldn't come up with much of anything on that. Got some post-contrast thin slice, gradient echoes, nothing. At that point, the technologist said, Adam, you got to come look at this guy. So he's been on the scanner with his arm over his head and supinated. And I go see his hand, and that finger has turned white, and it was cold. And I thought, what is going on here? So this technologist, who is absolutely tremendous, said, I got this new tool that we use for neuroimaging. Haven't used it in MSK. It's called TRIX. Why don't we inject them and see what the TRIX does? We're able to follow a bolus of contrast. So this is a post-contrast TRIX sequence, same slice, same location, and we'll start watching the flow. Look at that. The third finger has depleted vascular flow. So sort of crazy. Eventually it fills in. The symptoms were most prominent at the ulnar aspect of the third finger, and that's where the flow is most depleted. So I thought this was a pretty convincing MR finding, but what is it? I had no clue. Going back, the player said that, a couple of weeks ago, he felt a little rent in his hand, and I went and looked more closely at the proton density, and I think there's a little bit of a strain and a fascial rent there. Maybe I can sell you on a fascial rent here. This is the adductor pollicis muscle and tendon. So I think he did have a little strain there, but how did I put it all together? Well, we went on to do what I thought he needed to have, and that was a thoracic outlet dynamic MR. I got the arm extended over the head here, and this is the normal indentation at the anterior scalene. This is a normal study. The venous flow going in, and that was normal. So you can see the patient move here at the end. That was normal, so we're left with these initial findings. So we went to see the vascular surgeon. We went through the images together, and the vascular surgeon said, I've seen this before. This is a post-traumatic Raynaud's phenomenon. And sure enough, I found a case report from emergency medicine. It didn't have beautiful images like ours. But he's got this white finger that's typical for Raynaud's in one digit. He's got this depleted vascular flow, and he's got this little tear of the adductor pollicis muscle. So we think that the adductor pollicis muscle tear probably has impacted the vascular flow to the finger. Raynaud's, if you haven't dealt with it, it's not often an imaging diagnosis outside of interventional radiology, but it's depleted blood flow to one or multiple fingers. Surface of the skin gets white or blue when it happens, and it tends to be transient. When blood flow returns, the skin turns back to normal, and sometimes it's throbbing and sore. Warming the hand is the primary treatment. Most of Raynaud's is idiopathic, and it generally involves multiple fingers, but you can get a post-traumatic or a secondary Raynaud's from things like frostbite, atherosclerosis, scleroderma, cryoglobulinemia, which I don't know what that is, SLE, and even repetitive vibration trauma. And usually the diagnosis is made with a cold stimulation test. And treatments are generally calcium channel blockers and vasodilators. So here's a couple of typical Raynaud's angiography images, and it looks a lot like our TRIX image, doesn't it? So what is this TRIX? If you don't do neuro, you might not have heard of it, but I think our neuroradiologists are very comfortable with it. It's one of the timed resolved MR angiography sequences that are available from multiple vendors, and generally you get more than 20 images at the same location. At 1 to 2 frames per second, and you're following a contrast bolus. You can follow the arterial bolus or the venous bolus. So data from case-based samplings are combined to create the series of images that I showed you. This is what I thought he had, just as an ancillary, another case. This is another picture, and with his arm down at his side, you can see the arterial flow is beautiful, and with his arm up, you can see the compression of the axillary artery at the site of the first rib and anterior scalene. So that's what I thought he was going to have. It's not what he had. He has post-traumatic Raynaud's phenomenon in the third digit, and this is the best part of the case. So they gave him some calcium channel blockers, and he didn't do well with them. He felt nauseous. He's got to go back to Florida and resume his training for the rest of his body. So they treated him with
Viagra,
the little blue pill. So he went back to Florida as a pro athlete and a single person with a bunch of little blue pills, and resumed his activities. And actually, 3 weeks later, symptoms are completely resolved, and he's pitching in the major leagues. So my lesson learns are we should be aware of activity-related peripheral vasculopathies, including Raynaud's. When you're not sure how to solve a complex problem, if you want to be a strong musculoskeletal radiologist, leverage the experience that you have from technologists and maybe application specialists, in this case, MRI. Listen to the clinician who's examining the patient. I did not. I should have listened. And sometimes you have to accept when you're wrong, and I was completely wrong. That's what I have.
that's
is
great
amazing.
data.
Thank you. I love it.
That was amazing.
Okay. There's a question here for Paulo. What's your favorite muscle injury classification, and do you use it in your reports?
Yeah, I answered that on the chat, but this is really controversial, whether which classification to use. I think the most important thing is to try to establish the same language as the receiving end of the reports. So if your clinicians or physios like the BAMIC, use the BAMIC. If they like the 3-grade scale, use the 3-grade scale. That's usually what we do here. For the hamstrings, we most of the cases we use the BAMIC because it's a more detailed classification, and it has this particularity of checking the intramuscular tendon involvement. So this is what we do, but I think the best thing to do is see what your clinicians understand and what they prefer. And just to add one thing, I often describe a lot of even if I classify, I try to describe as much things as possible in the text. body of the report, because often there are some particularities that are not included in the classifications. They all have their limitations. So I often describe a lot of things.
Do you want to ask your question for him, Hillary?
Oh, yeah, I think he saw it. I can't remember. I mean, I'm sure Adam has, but I haven't really seen or don't commonly see injuries at the distal myotendinous junction of the biceps femoris. And I was wondering if this is soccer related or other.
Yeah, so we have we here in Doha, we take care of all the athletes in Qatar, but the majority of the athletes are, at least great part of the athletes we see are football or soccer players. So, but you are right. Most of the injuries are up in the proximal myotendinous junction and even in the conjoint tendon. But since we have a lot of athletes and we see a lot of hamstring injuries, then we often see distal ones as well.
I can say from an American football standpoint, this is an odd location. We see this injury with some frequency, but it's only in one subset of players. It's wide receivers. We don't see this injury at the T location in the big guys, the linemen, the linebackers. We see it in the wide receivers who often sprint and then slow their running.
Yeah, for sure, yeah. So the football players, they are often sprinting, and there is the kicking as well. So this is part of the sport as well. But yeah, for sure, the majority of the injuries are not in the distal myotendinous junction.
Adam asked if you use PRP in the athletes with hamstring injuries to accelerate healing.
Not all, but yeah, we use PRP, and we use we use PRP.
So I had asked Rosemary in the chat. I hadn't seen. I've never made this diagnosis. I thought those are beautiful illustrations of Batter's shoulder now that I'm familiar with it. But I thought I saw blunting of the posterior glenoid the way that we see in the dominant shoulders of pitching athletes, which is considered adaptive remodeling of the glenoid to increase the range of motion. But I imagine if we do see this in the batter's shoulder and the non-dominant side, it would be post-traumatic. And I wonder if it, contributes to exacerbation of their instability. What do you think?
Yeah, no, I agree. I think it can be a little bit confounding because, as I said, it can be more insidious in onset. And so maybe it's those patients that you do have more of that kind of chronic bony remodeling. And I put something in the chat to respond to that. I had another case, this guy, but he was right-handed thrower and a left-handed batter. So both the dominant, the right, it's what's causing this bony remodeling. It was pretty significant. He'd been playing since, he was in diapers, I suppose. Pretty significant bony remodeling of the posterior glenoid. I didn't use that case in this one because I didn't have all his history and his enrolled being signed, but I think it's interesting to see that. I personally, I have noticed that some blunting in all of these, whether it's, and you can have post-traumatic fracture as well, but if they start younger and they're batting more, I think that you can be more on that chronic kind of finding. Blunting.
Adam.
And also, I just have to say that I got interested in this case. I didn't know about it either. I got interested in this case because my son was teeing off. We were playing golf and his swing, he adducted his shoulder too much and he just fell to the ground with shoulder pain.
And does it happen in golfers too?
Yes.
Maybe your son?
Yes. Well, yes. And it has some of the research, and yes, can happen in golfers with the adduction. And it was actually Dr. Zoga who mentioned the batter shoulder to me because I really was not very familiar with it. So,
Beautiful. Adam, I have a question. I missed it. So this guy gets the Raynaud's only when his arm's over his head?
I think, Hillary, I mean, we went back and forth. The vascular surgeon and I talked this through. We think he is actually getting it when he grips something, because when he's holding his phone,
Yeah.
he's weird. He finger types with the other hand, and he gets it when he holds his phone. So maybe supination and gripping, but no, the over the shoulder thing I think was a red herring. I think he was supinated on the scanner.
So this is a chronic problem. He's always on Viagra.
I don't know.
You know, because I personally have Raynaud's, and I mean, a long time ago, somebody mentioned to me that they treat it with Viagra. I think there's I think the Sildenafil is marketed under a different name for treatment of Raynaud's. I think it's a different strength than for ED, but I'm not really sure. That's just crazy. Are there any other reported cases of traumatic Raynaud's?
Yeah, there are a couple of just single cases in the literature. One from the emergency medicine literature, and one from the vascular surgery literature. That's all I found.
Adam, may I ask you one question as well? Did you consider Botox for his Raynaud? Because this is something that I've seen people try to block the parasympathetic.
Yeah, no, that came up in the conversation with the vascular surgeon. I think they were hoping that this one was going to be transient as opposed to a chronic Raynaud's, but they certainly mentioned that as a potential treatment option.
Okay.
Wow. I mean, and then how do you target your injection? What are you?
You target around the arteries, I guess.
Uh-huh.
I think the ulnar, but I don't know, because this is just the third finger, so maybe go distal in the digital arteries. But if it was the whole Raynaud, then they target, I think, the ulnar and radial, and the arches, the arterial arches as well. But I'm not really familiar with this. This is something that I just read by more as because my wife has Raynaud as well. So,
but I mean, the Botox injection, that's temporary.
Yeah, it's temporary.
And crazy expensive.
Yeah, it's not cheap.
Okay, we don't have any other questions in the chat box, so thank you all for tuning in. The next session will be on May 17 with focus on rheumatology. Thank you very much. Bye-bye.